So Dr. Satish Chandra Gore is now very popular and well known internationally also. I still curse my fortune that I didn't know him long back. I knew him as a friend, but I was unaware of his work till about a few months back or maybe a year ago, when it was brought to my attention by one of the spine surgeons in Chennai. I WhatsApped him and he was very happy by the very warm response he gave and very rapid way in which he answered my questions. So much so that when the answers were long enough, he wouldn't even wait to type. He'll quickly make a voice text and send it off. And irrespective whether it's 6 in the morning, 5:30 in the morning or 12 in the night, he'll answer my questions within seconds, telling that he's a hypermaniac just like me. He is the father of minimally invasive spine surgery in India, and he is the one who has first published about sodium channel blockers and distal blocks for proximal trouble.
Good afternoon. I'm very happy to be here, and I must confess that I suddenly remembered that I'm still an orthopedic surgeon. I left orthopedic surgery almost for the last 20 years. Even though I'm a qualified orthopedic surgeon, I started my practice in 1983. First of all, I'll thank Dr. Prakash for allowing me to share my experience with you. And I can tell you that this is something which is so very fascinating that I have devoted my time, energy, money, efforts, everything to spine endoscopy for the last 20 years. Now, this is my teacher. I learned from Dr. Young, Dr. Anthony Young from Arizona in US. This is a picture I used to look like this in 1999. And this is a picture of my surgery where you see that the arrow is pointing towards a small incision which I have taken for the surgery which I have done. Now, I used to be a president of International Intradiscal Therapy Society. That is the first one. Now, this is a society in short which was formed by Lyman Smith. Lyman Smith, which many of you would know, was the person who introduced chymopapane to spine. That is the injection of enzyme from papaya, which was injected in the disc, which used to dissolve the nucleus. The second society is the International Musculoskeletal Laser Assisted Surgery Society, of which also I was a president. And I use laser in my work every day. And the third one is our Asian Academy of Minimally Invasive Spine Surgery, which we formed in 2001, and also American Academy, which we formed in 1999. So in short, I'm going to tell you what is the philosophy, what is the thinking behind this method in madness. Now the first thing is, let me accept that we are not overriding any red flags. We accept that there are red flags which would be related to the low back pain, which are in the form of neoplasia, choroidal syndrome, a fracture and infection. So we are not saying that these things should be treated by stitchless spine surgery or these things should be conserved, etc. We accept that they are indications for urgent intervention, and the intervention can be anything what works in your hands. You can do open surgery, microdiscectomy, endoscopy, whatever. I mean, you have to treat that in time. You can't neglect it. Now, why I changed and what exactly happened after that? After 16 years of my practice, I changed in 1999 and I left orthopedics in general. I was 43 years old that time. I closed my practice, I closed my hospital, I went to US, I got trained. Now this was a very, very big decision. But I can tell you I was very lucky in having my own spine practice before I started endoscopy. The main difficulty nowadays which I find is young people are attracted to endoscopy, and when they go out after training, they unfortunately don't have their own practice. And if you depend on the referrals for your practice in spine, it's very difficult to do that. Because the referring person also has a stake in that, also has an interest in treating the patient, also has an interest in prolonging the non-operative care for months together, and then at the end of that, when the patient comes to you, the patient says that I have no money, I have spent everything in my non-operative care, etc., etc. Why did I do that? I realized that what we are doing, I mean in those days and it applies even today, is absolutely irrelevant, imprecise, unpredictable, uncertain, and full of misconceptions. And the worst part is leaving no choice to the patient. It's like there is no alternative to surgery. Like that. Those arguments always go on, where the patient is told that there is nothing else which can be done. For example, I'll just narrate a short story. A patient comes to an orthopedic or a neurospine surgeon, and the patient says, "Sir, I have terrible pain in my back going down the leg. What do I do?" The surgeon says, "You know what? It can be anything. It can be this, it can be that, it can be even that." So patient says, "What do I do?" The surgeon says, "You need an MRI." The patient says, "Yes, sir, I have got an MRI. This is my MRI. What do I do now?" The surgeon says, "You know, this MRI shows a black disc, and there is something white here, and there is something more dark here, and all that. I can't really say. I mean, you are suffering for how much? 6 months. Oh, okay. Then you need surgery." The patient says, "Okay, if it is so, I am ready for surgery. But I have a very simple question. Will I be all right at the end of the surgery?" And this is a question which I can tell you most of the traditional surgeons cannot answer in affirmative. I tell the patient, yes, you will be definitely relieved of your pain. Why? Because we understand, diagnose and pinpoint the source of pain. Please listen to this sentence again. I understand, I diagnose, and I can pinpoint the source of pain or the pain generator. In fact, as I mentioned here, we are like vultures only looking for those who need surgery. Now, this is a terrible situation. Just think about it. A patient coming to you, and you as a surgeon are only interested if his straight leg raising is positive, probably indicating the need for surgery, and if the patient's straight leg raising is negative, then you immediately lose your interest and you say, "Oh, you go to a physiotherapist, you come back to me after a month, or you try this or you try that." You are totally clueless. The patient is also totally clueless. Now, this is a terrible situation, which I personally feel is one of the biggest tragedies of spine surgery. Why? Because all of us, I have no hesitation in saying, all of us are above average intelligence people. We have chosen this as a field of work. We have decided to devote our efforts to betterment of people's spine health or orthopedic health, whatever you call it. Now, at the end of that, you don't know anything, the patient doesn't know anything, and you're just going by some dictums which have been dictated 50 years back. So the first thing which we try to answer in every patient who comes to me with back pain and sciatic pain is, where is the pain coming from and why is it persisting? Now, this question, if you are not able to answer at the end of your examination or investigations, you should not treat the patient. I mean, you refer it to somebody else. Other thing which I will tell you is that do not feel shy or do not feel it below your dignity that you are treating pain. In fact, the main reason why a patient with spine problem comes to us is for pain. It's not for MRIs, it's not for fixation, it's not for the hardware and the heavy metal and all those things. The patient wants a clear-cut answer. Why am I suffering? What is it that I can do? What is it that you can do to make me better? And then the patient would also like to know, do I really need surgery? If I need surgery, will I need it today? Or I can wait for 6 months, or I can wait for 1 year? And then, will there be a natural resolution of inflammation? I use these words very, very specifically, and I don't use the word failure of conservative treatment. There's nothing like failure of conservative treatment. It's always lack of natural resolution of inflammation, which makes the patient have persistent pain. Now, the questions which I have enumerated here are the real questions to which a traditional surgeon or a traditional thinking has no answers. The next question is, how do we monitor non-operative or conservative care? We ask the patient every day, how do you feel now? Patient says, yeah, a little bit. After 8 days, how do you feel now? Maybe same. After 15 days, how do you feel now? Worse. Terrible. After 20 days, patient says, oh, what magic you had. The pain has gone away totally. What can I do now? You say you can start working, you can go here, you can go there. Again, 25th day, patient comes back, same pain, same location, same intensity. What do I do now? You have no answer. Just think about it. Conservative care, monitoring, zero. And you can't take an MRI scan every day Even though you may be owning an MRI machine, it's not scientifically proven that taking an MRI every day would really make a difference to your thinking. Then the next case is, what is a chemical and a mechanical cause of sciatic pain and back pain? I really tell you that the industry has seen to it that chemical component of the back pain is not talked about anywhere. It's like a secret. Nobody wants to talk about it. Why? Because those are the people who probably do not need surgery, who probably do not need intervention unless it is very severe. What are the stages of sciatica? Stages of sciatica, I'll be talking little more detail now, but stages of sciatica, stage 1 is when the nerve is mechanosensitized. It is inflamed. Stage 2, when it is mechanically compromised or mechanically compressed. That is when you have a straight leg raising test positive with some variations. And stage 3 is mechanical dysfunction, where you have a nerve which will have a sensory or a motor deficit. Now, what is the percentage of these people? The first stage, mechanosensitization, where the nerve is inflamed, which manifests commonly as knee pain and heel pain, is 80% in my practice. It may vary from 75 to 80 or 70 to 80 or 70 to 85, but it's the majority of the people who move around in numbers from one person to another in search of a diagnosis and a solution. The one which has a mechanical compromise or a straight leg raising positive is not more than 15%. And those who have a neurodeficit in a common clinical examination will not be more than 5%. Out of these 15 and 5, about half of them may need surgery. Now listen, this is a very important statement which I am making. About 90% of the patients, you can make a difference by giving a precise diagnosis and by coming out with a plan of action which works in every person, which works definitely in all those people. What are the frauds which are going on in stenosis assessment and management? I am using the word fraud with a very clear mind. I will explain to you what are the frauds which are going on. Then of course, for a traditionalist, you will know that what is the hidden zone of McNabb. Ian McNabb was a very senior celebrated spine surgeon who described that there is an area, if you go posterior midline, you take out the lamina, then you try to go towards the subarticular area, that is called as the hidden zone of McNabb. For your information, we endoscopists, we put our scope in the hidden zone of McNabb. So it is a zone which is absolutely 100% clear to us. We can watch that hidden zone of McNabb, and I operate all my patients under local anesthesia. Let me tell you that last 20 years, all the spine surgeries which I have done are under local anesthesia when the patient is fully awake and aware, maybe around 8,000 or more. And the patient enjoys the surgery, you enjoy the surgery because you are actually making a difference in real time to the cause of the pain. Now, I'll quickly talk about this point of quality of care by Cano. Now, Cano is a very celebrated management guru, and he says that there are 3 types of qualities of anything, generally in service. The one is called as the expected quality. That is, the thing is supposed to do what the thing is supposed to, is expected to do. Like a pen, you put it on paper, it should write. The second quality is more than expected. For example, there used to be an ad in between where people used to advertise a ball pen which will ride 100 kilometers or something. So more than expected. And the third is called as the excitement quality. Now this excitement quality is something which has now started coming in the cell phones, where you have a camera, you have this, you have a fax, umpteen number of things are there. Now this is more than a phone, this is more than expected. Now what is the point I'm trying to make? Cano says that there is an arrow of time, and then with time the excitement quality becomes the expected quality. I'm sure all of you agree that what was something which was very, very glamorous a few years back, now we take it as given. Even in iPhone for that matter. Let's say when you had an iPhone 10 years back, 15 years back, and today, I think probably half of you may be carrying an iPhone in your pocket. Now this type of quality is expected from you by the patients. The patient should be relieved of the problem. Patient should have an answer to his concern and a question that why am I suffering? And it should be an excitement quality, which I can tell you I deliver by my spine endoscopy. Then is aging and degeneration same? What happens in our practice commonly in our OPD? We try to equate these two terms, which is practically okay. But aging is not degeneration. Aging is asymptomatic. Degeneration is symptomatic. And are we changing the natural history of the disease? Now please listen very carefully what I am saying. We do not change the natural history of the disease. We are just trying to control the symptoms. We are not making any difference to the genetic code. We are not making any difference the way the disc behaves. We are just making the patient comfortable, and we are just taking care of the concerns and related factors which affect the activities of daily life for the patient. Now quickly I'll mention these few references, but one is very important. This is the first one, which was in CORR, written by Stephen Kuslich. The title of the paper is self-explanatory. This is called a tissue origin of back pain and sciatica. So what he did is, it is actually the subtitle is there, report of pain response to tissue stimulation during operations on the lumbar spine using local anesthesia. Now what Dr. Kuslich did is no more. He expired due to some infection. He was in Philadelphia. What he did is he operated open spine surgery, posterior midline surgery, and he said that every time I'll probe a layer, if that layer is painful, I'll inject local, then I cut further. Then I go below from skin, subcutaneous tissue, interlaminar tissue, interspinous tissue, ligamentum flavum, dural sac, on the side of the sac, front of the sac, undersurface of the facet, and the nerve, and then the posterior annulus. And when he did this study, he came out with the important conclusion that there are only 4 important pain generators. 4 significant pain generators in the spine. They are not paraspinal muscles. This is not ligamentum flavum. It is not interspinous tissue. It is not supraspinous tissue. These 4 are important: inflamed, mechanically compressed nerve, which gives sciatic pain; posterior annulus, which when affected in the center gives back pain, affected posterolaterally gives leg pain; third, facet capsule in the front, and anterior epidural tissue, and all these when they are inflamed. We'll talk about it a little more. So these are other references which talk about where is the pain coming from. Now, I am trying to point out to you a textbook or a book available on the internet, which is an extremely important book on the concept of pain, called as the Biochemical Origin of Pain. Please kindly read this book. It will change your life. I can tell you, it changed my life. You will understand the whole thing in a very different perspective. It is not a mechanical description of pain causing structures. It is basically a description of cytokines and the biochemistry involved in generation of pain. Now, all of us know that there are 3 common cytokines which are involved in pain, which we deal with. That is prostaglandin, interleukins, and TNF-alpha. Most of the painkillers which we use are treating prostaglandin. Some, like nimesulide, are good for interleukins. And there is no oral medication in the conventional medicine which we have for TNF-alpha. All the biologicals which are available are anti-TNF-alpha. But the funny thing is, steroid is active against all 3. Prostaglandins, interleukins, and TNF-alpha. So we have that cheaper alternative. Now, coming back to this concept, this is a publication by our colleague Rajashekaran from Coimbatore in European Spine Journal. And the thing is very simple. In healthy, there is no structural failure. In aging, there is no structural failure. In degeneration, there is a structural failure which gives symptoms. Why? Because the neurovascular system reacts to that structural failure. And there are many other points. The other point which is important is about nutrition of the disc, which is normal, reduced, and abnormal. Now this is an important feature of aging, that the nutrition of the structure goes down and slowly the system stops. That is aging. It is asymptomatic, and I'm sure many of us who had our grandmothers and grandfathers lived till the age of 90s and above were very happy even at that age, and they used to believe in graceful aging. That is no more so. It is painful aging now. Why? Because your structures are breaking down. Why? It's a different topic. We can talk about it in big detail. But please remember that in case of this structural failure is mainly in the form of annular tear. In case of facet, it is synovitis and degeneration of the facet and many other things. I'll talk about it as the time passes. Now, coming to a very important point, there is a big uncertainty in the mind of surgeons about what am I treating? What is it that exactly is happening inside? Can I predict my outcome? And this leads to this problem where on our side, the surgeon side, we have a lot of ignorance about this whole issue. On the patient side, there is fear about the risk of the surgery. And this is a very, very important issue which you can easily solve if you pay attention to the basic processes which are going on in the body. Now, I have one simple statement to make. Most of us, since we do not study the basic biological processes, we go by the duration, we go by the time frame. For example, you have a patient who has a collisus fracture. At the end of 6 weeks, you see him and you say, oh, your fracture is not healing. Now you should talk more about why the fracture is not healing, what is happening to the osteoblast, osteocytes, osteoclast, blood supply, etc., etc. Rather than saying, oh, it will take 3 more weeks, it will take 6 more weeks. I mean, that time frame thing creates a lot of problem. So please remember that. And here, please remember the patient wants you to say for sure that yes, I can take control of this. Now that starts with diagnosis. If you are able to diagnose this problem better, the patient is very likely to believe in you that you will be able to relieve it. Now, one more point I'd like to tell you that in my practice, in my thinking, I feel we are unfortunate that our teachers who had no technology and outcomes, etc., always taught us out of a frame of mind called as trial and error. Okay, please listen what I'm saying. This trial and error mentality is terrible. We must stop that. We should come out with what is called as method. I'll give you an example. I say that when I train my students from transforaminal endoscopy, I train pilots. I do not train truck drivers. I do not train engine drivers. Why? It's not that they are bad. I'm saying they have a wider margin of error. Whereas in my surgery, it's method. What is a method? A method is a set of instructions. If they are followed in a particular sequence, will always result in the same outcome. Okay, almost always. I'm sure I'm not claiming that I relieve 100% of my patients. My success rate is about 92%. 4% I cannot relieve properly, and rest of those 4 have some complication or some limitation. What I'm saying is, if you follow a method, I'll also tell you that worldwide people have studied this safety, this, that, and they have said that the most safe thing in the world today is air travel, not train travel. Why? Because it follows a certain method. The pilot will always land at an exact location. They will always look at all those consoles and take care of all those things and then fly the plane. It's not like somebody who forgets something, then they come back and then they go again. And no. So please come out of that trial and error mentality. Now, how can you come out of that? You must know the whole picture before you start this surgery or before you start diagnosing back pain and sciatic pain. You cannot say that I don't know this, I don't know that, I don't know that, and then you make a claim that I know the diagnosis. Not possible. I mean, if you don't know what is chemical radicalized, if you don't know the cytokines, if you don't know the biochemical origin of pain, you are going to miss it. So please remember, we want to come out of that trial and error mentality to a method. What you need to do is to create a database of innovative and inventive solutions and problems which are solved. In simple English, what I have written is, you need to interact with each other and find out what works with somebody, understand the method, which I am now trying to tell you in my case. Now, the biggest problem was we were diagnosing pain in the past based on unrelated, irrelevant images, and that was the end of our insight. Now, I'm going to ask you a question. How many of you operate spine under local anesthesia? Probably nobody. All of you operate under general anesthesia. Now see, the moment you make the patient unconscious, that source of information is cut off. Then you come back to the image level. Now about the image, I'll tell you a very peculiar thing which is happening nowadays. The MRI specialists in our countries do not touch the patient. They do not ask the patient what is their suffering. They do not examine the patient. They do not treat the patient. So they create a dissociation between the image and the symptoms at that level. And you further that dissociation. I mean, you don't care about the symptoms. You just want to look at the scan and say, oh, this looks bad. I need to operate you. That's very bad. That's very wrong. Now, I told you the work by Kuslich in 1991, which we just saw, tissue origin of back pain and sciatica. Then we had work by Markovic and David Schwartz in 1995, which I'm going to touch within a minute. And then we did our work around 1990s upwards. And then Dr. Young, my teacher, got FDA approval for the scope in 1998. Now I have my scope just to show you. I mean, just half a second. Now this is my scope, which we sort of got the system, which was inaugurated in 2010. And then we published in 2001 about evolving methodology of transforaminal spine endoscopy with a very specific emphasis that the pain arises from annular tear. And you have to demonstrate the tear in each and every patient, which I can by using my scope, which goes inside the disc from the side of the patient. Then we also published about in vivo visualization of pathoanatomy of back pain and sciatica. What I mean is, I can actually see the pain causing structure when the patient is awake and aware. I can probe that structure and ask the patient, okay, what is it? The patient says pain. I say, where? Back or leg? Patient says back. I will tell you something which is extremely important. I actually was pretty impressed with the first lecture today by Dr. Reddy about going to the rural areas and practicing. But I'll tell you one secret. You can still remain in the urban area, you can still compete. You concentrate on young people 25 to 35 with back pain. Huge number where almost all the clinicians are phlomox. They just don't know why it is happening. It is simple. It is posterior annular tear with a trapped fragment of nucleus in the posterior annulus at the central area. As simple as that. You remove that trapped fragment, the patient is absolutely 100% relieved of the back pain. Now, why this is important is, unless you know this, you're also going to miss that, and you're going to probably face more and more depressed and more unusual patients. I'll tell you one short story. I saw a patient, male aged 26, who came to me with whole body MRI scan. I don't know what that means, but he had scans right from head to the toe, and he was crying. He said, just 26. He said, sir, I'm miserable. Sometimes thoughts of suicide come to my mind. I said, what is happening? He said, about 1.5 years back, I started having pain in my back and my leg, and I lost my job, and then I lost my wife. I mean, she deserted me, saying you're good for nothing, and I have nothing in life to look forward to. Can you help me? I will tell you, the funny thing was, he had a simple posterior annular tear with a fragment in the L5S1 disc, and the moment we removed that, he was relieved in about 4 hours of our interaction. Now, I feel so bad about this person who is just 26. He had a lot to look forward in life, and he lost all that just because we are ignorant. In the morning we were discussing, Dr. Arup Mukherjee and myself, nowadays our patients suffer not because of their disease, but because of ignorant doctors. Let us accept it honestly that we are absolutely ignorant about what is happening in these people. Open our eyes, open our ears, open our mind, listen, read, interact, and work on it. So we also published on in vivo visualization, that is seeing the pathology when the patient is awake, probing it, and correlating the pain with that pathology, with the image, with the symptoms. And then in 2014 and after that, we have published some more. Now quickly, I'll show you those publications. This is the first one, which was published in 1995 in Spine by Markovic. And this is basically a study of the foramen, intervertebral foramen. Now see the unfortunate part. It's a natural orifice. Nobody teaches us the anatomy of intervertebral foramen in medical school. I don't remember my teacher teaching me anatomy of intervertebral foramen, but it's very bad. You should learn that anatomy. The second one is, this is an important concept which I'm telling you, is this, what I'm doing is I'm looking at the disc through my scope. This is an endoscopic picture during surgery. This is the posterior annulus. This is a tear in the annulus. This is inflammation. and this is called as a pain generator. Now, I'll repeat, this is annular tear with inflammation. So this is the interface between the structural failure and the body reacting to it. This is a pain generator. Now, if this is at the center, that is midline or posterior annulus, then you will have back pain. If this is posterolateral, then because of leaking cytokines and other mechanical changes, you will have leg pain or sciatic pain. So this is one of the important pain generators which I just talked about. Then this is also a very important slide. This is a paper by Helena Brisby in JBJS about pathology and possible mechanisms of nervous system response to disc degeneration. So what is really saying is body reacts to what is happening there, that structural failure, and causes the symptoms. And what is the system? The system is the nerve supply of the intervertebral disc. Now please remember, anterior 2/3 of the disc is supplied by sympathetics, so it doesn't reach your consciousness. The posterior annulus is very rich, which has somatic as well as sympathetic supply. And this is the area, I'll just draw that. Now this is the area which will have central annular tear. Just one moment. Just give me a second. Okay, now okay, it's not writing, that's fine. So central annular tear would give rise to back pain. Now tear posterolateral will give rise to leg pain. Changes on the front of the changes here will give back pain, changes here will naturally give leg pain, changes in the front of the facet capsule initially may give some claudication. When the change goes on and makes this smaller or stenosed, it will give more claudication. Changes in the joint will give back pain. Now I'll quickly come to that within the next few minutes. So there are 4 important pain generators. Now please remember, the uncertainty which we have about back pain and sciatica has come from a statement done about 60 years back, which is still continuing in most of the people's mind, is that you cannot diagnose back pain in 65% patients. Absolute rubbish. We can diagnose back pain in almost everyone, unless of course it's something very, very complex beyond apprehension by the human mind, which I don't believe. Now this is our paper about in vivo visualization. This was in 2010, and I'm going to show a couple of slides in the next presentation when I talk about what exactly is the pathoanatomy inside when the patient is awake 100%, and he can tell you that when you touch this, I'm getting this, when you touch this, I'm getting this. For example, I'll tell you, if you're looking at the axilla of the spinal root, if you press there, you get back pain. If you press on the body of the nerve, you get well localized, sharp, cutting, radicular pain. So that's the difference. Now, what changed after I started doing this surgery? The first is, I realized that there is an unnecessary, infinite list of causes of back pain. Whereas I'm going to tell you about 6 groups of symptoms which are caused by a degenerative spine. And I have a very simple thing to remember. If some pain in the human body is not trauma, infection and ischemia, it has to be neuralgia. It can't be anything else. And then facet-related back pain can be there, which gives rise to back pain initially, then claudication. Disc-related changes initially can give rise to knee pain, heel pain, coccydynia, and then there are 3 types of disc herniations, and we also have to look at healing of the annulus. Now you'll be surprised to know that I have attended more than 100 spine conferences. 2 topics are never talked about. Number 1, nerve supply of the disc, and number 2, biology of healing of the annular tear. Why? Because surgeons are not bothered. Why? Because they don't care. Why? Because, well, people are paying them in spite of all this. They want to put screws. They want to put 5.5 or 6.5 mm screws. absolute rubbish, absolutely irrelevant. And then we will talk about reality of the ligamentum flavum and what are the frauds. Number one is bony hypertrophy as a concept. Number two is the plane of the cross section in stenosis, which should be the facet plane, not the disc. Then the true anatomy of ligamentum flavum in cadavers, which I'm going to show you. 3D imaging of that anatomy, and then use of, I'll tell you what this is. This is the MRI software related thing, and use of ultrasound in our assessment. So one by one we will quickly go through this. Now this is our old degenerative cascade which has been proposed by Kirkcaldy-Willis, where we know that there are 3 stages which we talk about. One is dysfunction, instability and stabilization. So it's supposed to go through that. Please remember this paper, if you read, Kirkcaldy-Willis has said that this paper is not about symptom causation. It doesn't cause about why the pain is there. There is no correlation of these changes with pain, nothing. The third para of the paper says this is not a neurophysiological study. This is a study of 20 American cadavers to understand what the process must be. Instead of this, I have proposed a clinical cascade, which I'm going to talk within a minute. Now this is my emerging matrix, which is the basis of my surgery, and I'm going to tell you now those 6 things which we commonly see. Actually nothing new, we have regrouped things, you can say like that. The first thing is, we see patient with low back pain, which is vertical in the back or horizontal in the back. Okay, I'll repeat, pain in the back only, vertical in the back, horizontal in the back. Now this is the pain which is along axial skeleton. This pain may centralize or peripheralize on Mackenzie's test. All of you may be knowing Robin Mackenzie from New Zealand, who is a physiatrist who has a validated treatment methodology called as mechanical disc treatment or whatever, MDT. What you do is very simple. You ask the patient to lie prone on abdomen, on the belly, and extend your spine in lying position. Almost majority of the people would say that whatever pain which I have, let's say the patient has pain which is horizontal, it will shrink and come to the center of the spine. It will come to the lumbosacral junction in the middle. The pain is going down the leg. The patient does this and says, oh, my pain stops when I do this. This is called a centralization. Now, on the contrary, if he does this and the pain goes on the sides, it is called as peripheralization. What it means is, if the pain centralizes, then the annulus is good. The annulus can heal. The annulus has good integrity. And then this distal block is effective, then I conserve these people. I'll talk about the distal block very soon. And I also use the test, my test about feeling the sciatic nerve for detection, confirmation and monitoring the treatment. So this is a very important point. A patient comes to you, you analyze the patient, you operate the patient is relieved, goes home, comes back for follow-up after 10 days and says, oh my God, I have the same pain. Now I'll tell you something funny. When the patient comes back to you after surgery with the same symptoms on the 10th day of surgery, I asked one of my colleagues, what do you do? Now, very diplomatically he said, the answer will depend whether it is my patient or it is my friend's patient. So I said, what do you mean by that? He said, if it is my friend's patient, I will ask for MRI, and if it is my patient, I will do Mackenzie's test. Now, if you do Mackenzie's test and if you feel the nerve, and the nerve is very tender, and you inject distally, and the pain goes away, you don't need an MRI. You can say this is chemical radiculatis because of the opening in the annulus which is still leaking. But commonly, I'm sure most of you may be following the second part, that is the patient coming to you within a few weeks of surgery, you immediately say you need an MRI, and probably based on that MRI you will say you will need repeat surgery, and I cannot guarantee that you will be relieved by the surgery. Now this nonsense should stop. Now in image, we need to do the image in these people to confirm the containment, that is the disc is still, the outline is still okay. I mean, whatever is happening is inside the disc, not outside the disc. And what we have commonly observed is there is a chronic inflammation with an annular tear with a trapped fragment of nucleus which gives the persistent pain. So back pain, vertical or horizontal. Now what is this vertical and horizontal? Commonly, vertical is associated with L4-5 disc. and almost always horizontal is associated with L5S1. I would put it the other way. If the pain is horizontal, it has to be L5S1. Now, L5S1 is commonly associated with heel pain. It is also commonly associated with coccydynia. I'll tell you, all of us see a lot of patients with coccydynia. They carry those cushions and tires and tubes and a number of things with them because they are unfortunately not able to sit properly. They get a lot of pain in the coccygeal area. Simple thing. Make the patient lie prone, extend the spine. If the pain shifts to the lumbosacral junction, then doing this exercise of extension can stop the pain without any other treatment. Maybe some anti-inflammatory. Now what do we do for these people? We have transforaminal access, endoscopy in a awake aware patient. We remove these strap fragments and the pain in the back can be relieved by removing the strap fragment. I can guarantee you. Now I'll tell you something still more interesting. If you concentrate on young age group of 25 to 35 and only concentrate on back pain, no sciatic pain, no nothing, just back pain patient, I will guarantee you within 5 years you can be a billionaire. Seriously. I mean, I'm not promoting commercial part of it, but I'm just telling you the numbers are humongous. You will not believe this. People are just suffering, moving with files from one surgeon to another. Nobody knows anything. Because the MRI fellow writes some report, he is not bothered what should be done. Surgeon doesn't know anything because the outline of the disc has not changed. And well, the patient moves from place to place. Second, low back pain which is paraspinal, not in the midline, not axial, on the side. And the important point is when you ask the patient about back pain which comes from the disc, they show with the palm or with the hand. They show like this. Here. If you ask them about paraspinal, they will show with the thumb. They will say my pain is here. Both sides of course. I can't show with both the hands, but they will say like this. They will show with the thumb. So this is paraspinal pain. And what happens? This pain increases with extension and there may be a lag. It is called by one of my friends as a chair exit test. That is, let's say we sit in the chair for half an hour and you get up from the chair and you will find at least 10 to 15% of us will find it very difficult to straighten. So there is something which is going on in the facet. The pain is well localized, it is paraspinal, extension increases the pain and rotation increases the pain. These patients will tell you that when I turn in bed in the morning or late in the evening, I get a lot of pain. Degenerative changes are in the facet. Treating ascending and same level medial branch of dorsal ramus relieves the pain totally at least for 2 years' time. It may be ablated on the lateral wall of facet on the transverse process. I'm going to show that within the next few minutes. And if in a young person with non-stiff spine, you can block the pain by giving an injection on the tip, on the side of the pedicle. Many of you who put a pedicle screw, just go outside on the dorsal aspect of the transverse process. On the cephalad margin, you have the nerve. I will be showing that within a minute. And other pathology, that is if it is too severe, you treat it by facet denervation. Now the third one, which is much more important and very common, is a spot patchy pain along the lower limb. What is it? The history is, there is no history of trauma, there is no infection, there is no ischemia. The patient says, I just have pain. Commonest is pain in the knee. Now I'm going to tell you what this is. I published this. Pain in the knee, which is on the lateral aspect of the knee. The pain which is inferolateral to the patella. The pain which is posterolateral in the popliteal fossa is almost always sciatic pain. The pain which increases on walking in that area, the pain which is associated with neurological symptoms like tingling, numbness, heaviness is almost always sciatic pain. I'll tell you something which is much more important for an Indian perspective. Most of us sit on the floor with our legs crossed, right? Now you will find some people will come to you and say that, oh doctor, recently what has happened is I cannot sit with my legs crossed because if I sit within 5 minutes I must make my knee straight. Otherwise the leg becomes numb. Otherwise I can't sit. It's very difficult. I mean, you see these people in satsangs where they are sitting there all the time changing their position. They are not comfortable in that position. This is a moderately severe non-stretchability of the nerve, which I call as a moderate straight leg raising positive. Please remember, all these patients have sciatic pain, all of them. And I would like to debate this point later on with Prakash about his proximal femoral osteotomy. I have some different thoughts on that. I personally feel many of those patients would be having reduced stretchability of the sciatic nerve because of the virus, and you remove this thing, you make the nerve more relaxed, which I can treat with something which I am going to talk within the next few minutes. Now the cause is proximal annular tear, can be seen as leak in discography, which I am going to talk very soon. And the basis of this pain is mechanosensitization of the nerve, where pseudomonopolar axon nature of nociceptor is involved. There is sensitization, pain is felt distally, but the affection is proximally, inflammation because of leak. Now this also we are going to talk little detail. The axis is transforaminal. What we do is we seal the tear and we induce the healing by platelet-rich plasma. Now on that platelet-rich plasma, I'll just continue where Dr. Mukherjee left. It is very simple to prepare platelet-rich plasma. What you do is you need a centrifuge. Centrifuge is manufactured by an Indian company called REMI, R-E-M-I. It costs anywhere from 5,000 to 7,000. It's a small centrifuge called as doctor's centrifuge. What you do is very simple. You take a sterile, autoclaved, plain tube without anticoagulants. Take 15 cc of blood from the patient before your procedure, put it in the tube and spin it at 3000 rpm for 10 minutes and you get platelet-rich plasma. Okay? You make that thing stand for 10 more minutes, then you get what we call as a platelet-rich fibrin, which I'm going to show you after some time. So PRP is very easily prepared by spinning 15 ml of blood in a sterile autoclaved plain tube in the centrifuge, 3000 rpm, 10 minutes. Nothing else is needed. We did the costing of all this. We have done a lot of research on this in National Center for Cell Sciences in Pune, and we know what happens when we grow the disc cells in PRP, disc cells in normal saline, etc., etc. But that's a topic for some other day. So we use PRP to close the tear. Now here I also mentioned of heel pain. For one, I believe that the heel pain is a manifestation of the first stage of affection of S1 root. I do not believe in the nonsense of plantar fasciitis. I also do not believe in tennis elbow and all those things. I also know that most of the female patients in the middle age will come to you with pain here in the trapezial area at the superomedial angle of the scapula. This is a discogenic pain. This is not myositis. This is not fibromyositis. There's nothing like fibromyalgia. I'm always surprised to see that fibromyalgia is a diagnosis only in the UK. All over the world it is not there. I mean, why it is so, I don't know. Maybe in the right vein I can criticize that. Now, sciatica, pain distribution, dermatomal or non-dermatomal. Now, please remember, I had a debate once with, what's the name? Organic Science of, I slipped the name. Okay. So it could be a non-dermatomal distribution. In that, you feel the nerve, use the distal block to detect the chemical component, stage the sciatic pain, check the SLR, check the neurodeficit. Images may be helpful also to typify the nature of herniation. Now I'm going to make a very important statement here. Please listen very carefully. And this is also addressed to Dr. Prakash. You see, there are three types of herniations. Three types of textures of the herniated material. One is called as a soft herniation, where you have a piece of nucleus coming out of the disc, which is pure nuclear piece, and it generally is sequestrated. Now this piece definitely goes away on its own in about 2 months' time. You just allow the phagocytes or the macrophages to take care of that piece. The second type is called as a firm type of herniation. Now this is a herniation where you have a nucleus and an annulus with that. A piece of annulus is also there. This normally takes about 6 to 8 months to go away. And if you are able to control the pain, if the patient is able to understand that process of healing, you may wait. There is no need to undergo surgery. It's not mandatory that you do surgery. Nowadays, surgery is advised because of economic reasons. A patient cannot remain in bed or remain away from work for more than 6 months or 8 months. That's why we suggest that if you want a rapid resolution of the inflammation, we would rather remove that piece. Number 3 is a herniation which is called as a hard herniation, where you have a nucleus, a piece of annulus and an end plate fracture. Now these are the pieces which take anywhere about 2 years to go away. And I always remember at this time that there are a lot of people whom I know who tell me, you know, Dr. Gore, whatever you do, at the end of 2 years, everything is same. I say, no, you are twisting the statement. My statement is, what you need 2 years for to achieve, I can achieve in 1 day or 4 hours. So, 2 years is all fine. We understand the physiology, we understand the healing, but the argument can always be twisted either way. I would be one in favor of telling the patient that yes, it can heal in 2 years, but there is uncertainty. At the end of 2 years, suppose it doesn't heal, you may have to go in for surgery. And if somebody is there who says, well, I am Lord, I have enough provided for my family, I can just rest at home. I say, okay, no problem. I mean, there are no demands on your body. And the next point is, whatever you do for all these patients, the disc is permanently changed. There is one more thing which I am going to tell you which nobody knows. A normal young adult Indian person, aged 25, has a nucleus of about 10 grams. How do I know? I weigh all things which I remove and I have confirmed that it is about 10 grams in 25-year-old person. Every 10 years you lose 1 gram of nucleus. So aging, say a person comes to me aged 65, the disc will have only 6 grams of nucleus as a natural change. It is not pathological. Just because the thing is collapsed doesn't mean anything. It is a natural change because it is lack of nutrition, etc., etc. Then, if you remove the herniation, which is more than half of the existing nucleus, the disc will collapse very rapidly. Now, those are the people where you may need something more than just removal of that piece which is causing the problem. Now, access in these patients is transforaminal. All locations, what I mean is, I tackle cervical, thoracic, lumbar, D12, L1, L5, S1, central, paracentral, foraminal, extraforaminal, up migrated, down migrated, behind the body, everything. I can remove all of that under local anesthesia, definitely. The second is this tackle by endoscopy. I have designed a hook, which is there in my instruments if somebody wants to see. We remove the fragment, we use PRF plug. Now, I'll tell you one secret, which is a negative of my technique. The negative is, when I operate on my patients, I'm actually making one more opening in the annulus to put my scope, which is a negative. So I have to take care of the annular healing at the end of surgery as to bridge that opening. I have already published on this. I have written a chapter on annular behavior and management in one of the textbooks which has come recently about 6 months back, and maybe one of these days I'll share the PDF of that on our group. So surgery is stitchless, it is under local, it is awake in our patient. Then we go for claudication. Now I'll go through this little quickly. This is where the patient's pain. Now mind you, pain which is because of disc is always more in sitting. Pain which is more in standing and walking is always because of claudication or stenosis. And pain which is more at night or lying down, you have to be sure that you're not dealing with a red flag. So pain which is more in standing, walking, you note the time and you note the walking distance which the patient can take before and after. There is a self-filled questionnaire which I will show you in the next few minutes. And in these patients, now this is something very important which we have understood. I'll tell you. You see, what happens is, unfortunately, few of us don't even know about this, so we operate the person. At the end of the surgery, by evening, the patient says, I cannot pass urine. I mean, I have retention. And then you have a problem. Then you have to catheterize, and you don't really know what is going to happen. I will give you a simple tip. All these patients are in my setup. All of them above the age of 65, I do a post-void residual urine estimation on ultrasound. How is it important? If it is more than 100 cc in a male and more than 60 cc in a female, you already have a neurogenic bladder. Okay? You already are dealing with a bladder which is not functioning properly. These are the people whom I tell that you are most likely to need a catheter for 6 months. They may not need, but I just warn them. Why? Because I will make this statement which is very important is, whatever you talk before surgery is science. whatever you talk after surgery becomes defense. Please remember this. Don't fall in that trap of not making your patient aware of these things. Spine is stable in flexion extension. If it is unstable, we will see the next. Disc is collapsed to allow the superior articular process, that is the facet, slide upwards. We do a coronal oblique imaging. I'll show you that. Then dorsal root ganglion. Now this is a very important thing which you have to know. You see, actually back pain and sciatic pain is a malfunction of the dorsal root ganglion. Dorsal root ganglion is a mini brain in the foramen. It is in the foramen at 4-5, just outside the foramen at 3-4, just inside the foramen at 5-1. Whatever is happening in the micro environment of the dorsal root ganglion. Now, if you quieten the dorsal root ganglion, patient is happy. That's what we do with gabapentin and all those medications. So this is a very important structure. Location, intraforaminal, intracanal, etc. And respect the vascular cause mainly may be venous or arterial. You may have hypoxia or you may have venous congestion in that patient which may give rise to claudication. Now this is the place, venous, where all our traditional Ayurvedic medication is supposed to work by multiple enemas because it reduces the congestion in the Marston's plexus and the patient can feel better. What we do access is upper foraminal, we target the tip of the SAP, superior articular process, and surrounding hypertrophic tissue, which I will be talking in the next talk. There is no bony hypertrophy, so scraping of the surface may be adequate. What I mean by this is, you see, we have been hammered by this statement, there is bony hypertrophy. I will tell you, and all of us know, that in human body, after the age of skeletal maturity, no bone can grow. No bone, no exception. There is a growth of soft tissue which may become calcified or ossified. But this is not bone which has Haversian system. So bony hypertrophy is a misnomer. You don't fall in that trap. The last is unstable spine and claudication. The instability may be symptomatic as claudication. And there is an unanswered question in this. I'll tell you what that. We don't really know how much instability causes how much symptom. So there is a lot of gray area there. Now, if you have a patient who is say 70 years old and had changes of degenerative stenosis at L2-3, L3-4, L4-5, L5-S1 and has a listhesis at L4-5, then the question is, would you operate all levels? Will you operate only one? We have an answer for that, I'll tell you. We ask the patient to fill up our questionnaire, which I'll show you, do ultrasound for post-void, neurological exam, dynamic imaging. We know the adjacent segment affection is known in these people. We isolate the pain generators and we do what we call as hybrid surgery. And pain generators can be accessed through the foramen, etc. Now this I'll talk little detail later on because now I'm just trying to make it more lighter. This is a group of people who are sitting to solve the problems, and this man, who is the chairman of the meeting, is saying, to address this problem, we need to utilize our thorough system of root cause analysis. I will begin, if I may, by pointing out that it is not my fault. I mean, he's just trying to tell his crowd that he doesn't know anything. Let's try to find out. So let's go ahead and see. Now, algorithm for back pain, quickly. This is what I do. Back pain, now I already explained to you these details. They will slowly fall in place in your mind. Central pain, axial pain, pain on the side, pain vertical 4-5, horizontal 5-1, centralizes on extension. Then you give medical treatment, extension exercises, intradiscal injection of steroid or whatever you believe in, ozone, PRP, whatever. Pain doesn't centralize, you do a discogram, put a needle in the disc, put dye, try to find out that tear, try to find out whether it is leaking, try to find out whether there are fragments, and then no fragment, medical treatment or injection, fragment, remove the fragment. If the pain is on the side, which is facet, medical treatment, facet injection, facet denervation, if the pain is very severe. I'll tell you, I had a very senior ophthalmic surgeon from southern part of our country who started intraocular lens implants some 50 years back. He came to me saying that, Dr. Gore, I'm miserable. I have such a severe pain in my back at night that I must get up at 2 o'clock. I take warm or hot water bath, then I can again sleep for 2 hours, and then I again get up and I am again in pain. And this is going on for about 2 hours, 2 years. What I did is simple. I made him lie on the table, extend the back, the pain was severe, paraspinal, well localized. I put a needle, I gave lignocaine, 1 cc at those 4 spots. He said my pain has gone away. Next day I did a facet innervation. He was fully relieved of the pain. I will tell you something very interesting. The next day when I went to see him in the ward, in the room, he said, Dr. Gore, I am very happy. For the first time in the last 2 years, I slept without any disturbance. And for this, I am giving you my gold watch. So he gave me his watch. I said, no, I won't take that. I am happy that you are relieved. So this is the algorithm for the back pain. Now quickly, pictorially, this pain is 4-5, this pain is 5-1, and this also may be associated with coccydynia or groin pain. Please remember, groin pain also is a very common association of L5S1. In fact, if a patient comes to me with horizontal pain in the back, I ask the patient, do you have heel pain? They almost always have. Do you have groin pain? Do you have coccygeal pain? These three areas must be asked about. These are commonly associated. Coccydynia, very common. And here, I am not saying that there are no pathologies of the coccyx. I am saying if there is no trauma infection, then the most likely cause, and if the pain centralizes on extension, is almost always L5S1 disc. Now, facet pain, as I said, it is generally well localized on the sides, increases with extension and rotation. Now, this is crystal clear. I hope you remember this. Now, this is Mackenzie's test, which is equivalent to checking the annular integrity. You can tell the patient, I'll tell you something which is very interesting. I have done my fellowship in neurosurgery in Stanford University in California. I worked in intraoperative MRI. So what we used to have is a two donut MRI. You stand inside the MRI, patient lies across the MRI machine. You operate inside the MRI machine. What we did in those days is to see what happens when you extend your spine. What happens is the nucleus moves to the front and the posterior annulus is decompressed naturally. That's why the pain goes away or centralizes. So this is a very important test. Please read. There are a lot of publications by Donnell's son, D-O-N-E-L-S-O-N, Donnell's son, who is a disciple of Mackenzie. Now this is quickly about discography. Now I'm going to tell you what we have seen. Male aged 22, very severe back pain, acute onset, and this looks fairly normal. Now I know I can always show you the cross section, etc. But we did a discogram, this is what we found, and this is what was causing severe pain. I hope you can appreciate that this looks fairly normal, but here the dye is leaking up to the posterior annulus, which is seen in the CT discogram, where the dye is coming right up to here, meaning that the nucleus has now come up to that border. Second patient, male aged 32, acute onset low back pain. The scan looks fairly normal. These two discs are fairly normal. Here, there is a tear towards the lower end plate, which is seen here where the dye is slowly leaking outside. So discography has an important role. Unfortunate part, please now listen very carefully. Unfortunate part is the industry has seen to it that discography goes in disrepute by saying discography, it is controversial. I say, have you ever done, read, heard, assisted? Nothing. Why are you saying, no, I heard that it is controversial. But don't believe those who don't even know what is discography. I can tell you that you can do a discogram, which is a good practice to put a needle inside the disc. And in fact, when I show my instruments of my set, which is by Culture, just show me the needle. Yeah. So we use this needle. Now this is a needle which is either 8 inches or 20 centimeters long, or a 10 inches or 25 centimeters long needle, 18 gauge, 1.2 millimeter in diameter, and we do a discogram, that is the injection of the disc. Now, algorithm for the leg pain. Now this is very important, and this is where I'm going to dilate a little bit on this. I'm sorry, but I'm taking too much time, I suppose. So should I cut down? Okay. Yeah, thank you. So here what we do is, there are 6 questions. Now for all my younger friends, these are the questions which you ask. Is the pattern sciatic distribution, that is the location of the pain? Is the pain somewhat like sciatic pain? What is the intensity and when the time, what is the time when you feel that pain? What is the quality of pain? What is the relation to position and activity and non-painful sensation? I mean, you ask the patient, do you have pain in sitting, standing, walking, lying down, bending on the side, front, back? That clarifies. But remember that in that modality of assessment, you are not actually diagnosing the pain. You are just making an equation of the patient's body movements with the occurrence of pain. Then you see if it is sciatic pain, which root. Most of us have a habit of diagnosing the pain by thinking of the dermatome. Now the dermatome is 100 or more years old concept. They have not been revised. I can suggest you an article in BMJ Neurology called as Dermatomes and Dogma. Please read that article. What it means is you cannot be so sure about a dermatome being this or that. For example, big toe is L5, almost always. May not be so in some people. Okay, so please remember that. So if sciatica, which root, if it is this, which this, then you go for invasive imaging, that is the discogram which I showed you. You go for non-invasive imaging, that is MRI. And pain could be inflammatory or mechanical. Is it resolving or is it persisting? Then why is it persisting? And most important statement here is, at the end of these questions, you must conclude about the status of the nucleus, annulus and the nerve root clinically. I'm not saying you do MRI at this stage. Then this is the algorithm for leg pain. The main base is my sign, which I have published and I think I have already distributed on our group. Pain is lateral aspect of the knee or the leg, which is L5. Pain is at the back of the leg or heel, which is S1. You ask the patient to extend the spine while lying prone. The pain centralizes and then we give a distal block, which I will show you in a minute. Then if the pain centralizes and the distal block helps, then you give medical treatment and this person is definitely going to recover without surgery. You can definitely predict that you don't need surgery. Now I'll tell you something. I treated one very senior industrialist in Pune by my algorithm, and then when he came back to me after long follow-ups and all that, I asked him, what is your impression about our methodology? He said, Dr. Gore, you are a surgeon. If a surgeon tells me that you don't need surgery, it is extremely important than a physician telling me that you need surgery. Because a physician has never done a surgery. You are a surgeon, you can do surgery, but you are not doing surgery, which means something. So it's very important about this. The other side is the pain does not centralize. That is, the patient does like this and says, my thigh is paining. Now this is also a very important test, which we do intraoperative. I ask the patient to extend his back at the end of the surgery, and the patient must confirm that the pain which was there before surgery has gone away. I hope you understand the point. The patient does this on table because he is awake and says, oh, there is no pain. My pain has gone away. And the distal block doesn't help. The SLR is positive. There is a neurodeficit in this SLR. I told you the moderate form is the patient says, when I sit like this, I must make my knee straight. Otherwise, my leg goes numb or it becomes more painful. There is neurodeficit, then you do a discogram or an MRI. Nowadays, we prefer an MRI. If there is no fragment, you go for this non-operative treatment. If there is a fragment, you remove the fragment. Now, quickly, I'll tell you what we see in the MRI. Now, this is important. Please remember that when you see an MRI where the outline of the disc is not changed, the disc looks normal in the outline, almost nobody knows why the pain is there. Why? Because the MRI has a big limitation. The MRI does not show inflammation unless you use gadolinium. So, if the MRI person says the MRI is normal, doesn't mean anything. I always tell these MRI people in my town that you people are, I call them as Narad. You know, most of us know about Narad, who is a person who will always try to stimulate and instigate a person to fight with each other. So they are the people who give a report. The patient comes to you with that report and starts taking your cross-examination. Patient says, you know what, he said that there is a disc herniation. I say, who is he? I mean, is he going to treat you? Has he touched you? Has he examined you? Nothing. Don't tell me about somebody who has never even seen a surgery in his whole life. So this is no change in outline. What is happening here? There is a leak of cytokines, where the nerve is involved, the sympathetic chain also may be involved, and you may also have problems in the traversing nerve. So the pain could be anything. It could be L5, it could be S1, it could be both, it could be knee, heel, buttock, etc., etc. Here, these are the stages of degeneration. There is normal grade 2 where there is graying and there is a bar here, further graying, loss of distinction between nucleus and annulus. This is a collapse. This is aging if it is asymptomatic. This is degeneration if this causes symptoms. Now this is a patient where you see there is something happening here, there is a fragment which is coming out, the outline of the disc can change, the nerve is involved in inflammation as well as mechanical compression. So the straight leg raising may be positive and the patient may have affection of the sympathetics, giving rise to some funny things like dysesthesias, burning, localized, autonomic nervous disturbance. I'll tell you something, if you are very observant, there are two things which I want to tell you. There is one paper by a person named Charles Gunn, who was the chief of Canadian Compensatory Board. The title of the paper is Subtle Signs of Pre-Spondylosis. Please read this paper. This was in JBJ's British volume long time back. And the second thing is, if you see a patient who has an L5S1, S1 related problem, a female patient going on for a low grade chronic thing, you will always find that they will have a big leash of vessels behind the lateral malleolus. That area would be full. This is autonomic disturbance. You treat that patient, the nerve becomes okay, that fullness goes away. That is what we have observed. One more thing I'll tell you, I see a lot of patients who come to me for recent onset medial arch collapse. This is L4-5 related problem. I do not believe in anything else. A foot going in valgus, which was normal a few years back, is always degeneration of the disc and a nerve related problem. Most of the people won't agree, but I can show you hundreds of people like that. Next is where you have a sort of sequestration. Now I told you that if this is the only fragment, this definitely goes away, 100%. You just give an injection, give steroid, ozone, PRP, wait for a couple of days, the problem goes away. But if it is herniation plus annulus and herniation plus annulus plus end plate fracture, you counsel the patient. You tell the patient what is expected and then let the patient decide. We actually say that in endoscopy we have introduced a concept called as shared decision making. That is, I tell the patient, if it comes to surgery, I would operate. But you have to decide whether your suffering is so bad that you need surgery or you want surgery. According to my estimate, you need surgery. Why? Number one, on extension the pain is peripheralizing. It is not only inflammatory. You have maybe neurodeficit, EHL weakness, plantar plexus weakness, T-band weakness, etc. And your straight leg raising also may not be positive, partly, fully. So I am suggesting you surgery if you want to rapidly come back to normal. Please, your natural history of the disc is not going to change with my surgery. You will still have all the possible age changes in your body. I am not making you 20 years old. I am not making you younger by my surgery. In fact, if the fragment which I remove is 1 gram, I am making your disc 10 years older. But remember, I am not doing that. Your body has already pushed out that piece on the nerve, so I am removing. Now please remember this. You please tell the patient. Now one more thing which I would add to, I don't know who talked in the morning about consent. I have a consent where I have attached my references. I mean, at the end of the consent there are references. These are mainly for the Google generation who comes to you and says, oh, why so much? Why have you written 10 lines? I say, I have no time to argue with you. All the details are given in my references. You please go, read and come back. And one more important thing, I also have a post-operative consent. What is the importance of post-op consent? After the surgery, my patient is relieved of the pain. So I tell him, your pain has gone away because the fragment is removed, your nerve is free, there is a little bit of inflammation, you may have lingering back pain for a couple of days, etc. And then, now your recovery is your responsibility. If you do not exercise to bring your chronological age and the age of the disc in unison, you are going to suffer. You are going to suffer every time you travel, you jump, you go up the stairs very rapidly, etc. What I am saying is if your disc heals properly, you will be free of symptoms definitely. And that healing has to be aided by you, as Dr. Mukherjee mentioned, by good eating, good exercise and attention to all the deficiencies and correctable factors. Now MRI, I have 3 points to tell you. In 30% of the patients, MRI lack correlation. This 30% is actually 66%. On one side, the MRI looks normal, but the patient is suffering. On the other side, MRI looks terrible, patient has no suffering at all. Why this happens? Because inflammation is not seen in the MRI and the patient may be having chemical radicalitis or chemical problem. So remember, now what do we see in an MRI? First is low intensity signal from the disc like this, a black disc, which is nucleus dehydration, matrix degradation, etc. And this is used in Furman grading, which I showed you, those 6 grades. Second is, this is 100% sensitive but has a low specificity. Number 2, which we see is here. I hope you can see that white dot, which is there at the back of the disc. That is called as a high intensity zone, which is showing a mucinous degeneration of the nuclear material in the annular tear, which could be painful. And number 3, you see these modic changes, that is changes in the end plate, about which I am not going to talk in detail just now, but you can note these are changes in the end plate. Main thing is they indicate the chronicity of the problem. I'll tell you something, if a patient comes to you like this, you can safely predict and tell the patient that I am sure you are suffering for the last 1.5 years and this is chronic inflammation. You may need to do something more to take care of that inflammation. Now we come to the silent bystander or the sentry. What I mean is the nerve or the dorsal root ganglion. The dorsal root ganglion, now just listen to this concept. Dorsal root ganglion is at the top of a cone here. And there is a cone below. Cone, you know, it's not triangle, it's a 3-dimensional structure. The base of the cone is formed by the dermatome. And the DRG is sitting in the foramen at 4-5, just outside at 3-4, just inside at 5-1. So that dermatome, that myotome, that sclerotome, everything is controlled by that DRG. It is a functional spinal unit controlled by that dorsal root ganglion. And what happens is, many times, the dorsal root ganglion suffers because it is just lying next to that thing. Now this is the important part of my talk, which I initially I was invited for, is about this unipolar or a pseudo-unipolar thing. Now this is a cell body, this is towards the middle, towards the central, this is towards the periphery. This body is in the dorsal root ganglion, there is an axon, there is no axon and dendrite. Okay, there is an axon alone, which has 2 branches, and this may be in the skin, etc. The DRG has the cell, this goes in the center. What is the importance of this? Let's see this quickly. Now this is the importance. What happens is, this is the dorsal root ganglion, and this description is mainly about sodium channels. And what happens is, because of this nature, whatever is happening here may be perceived as happening here. That's why in case of annular tear, you get pain in the heel. The heel is normal. And you give a block here, the brain feels that it is being given here. Because this cell is what is giving the brain the sensation of pain. That cell is sending signals to the brain that this is painful. I hope you understand this point. The central end and the peripheral end are treated by the brain as same because they are the branches of the same axon. You may read this in detail after we send you this. Now this is a short video which I have taken from YouTube. I would like you to see. This is about 2 minutes. Just listen.
Plasma membrane. Voltage-gated channels open and close in response to an electrical voltage, so they are affected by changes in electrical charge around them. When a neuron is at rest, a charge difference is maintained between the inside and outside of the cell. This charge difference is produced and maintained largely by active transport using sodium-potassium pumps. The pumps send sodium ions out of the cell and bring potassium ions in. While other channels allow some flow of potassium ions back out of the cell, the sodium ions cannot easily get back in to replace the lost positive charges. The overall result is that the exterior of the cell has a net positive charge and the interior has a net negative charge. The difference in charge between the interior and exterior of the cell is called the resting membrane potential. A nerve impulse begins when a stimulus disturbs the plasma membrane on a dendrite, causing sodium channels to open. Sodium ions flow into the cell, lessening the charge difference at that location. If the change is enough, it will cause nearby voltage-gated sodium channels to open. This allows so many sodium ions to flood into the cell at that location that the membrane there is depolarized, with the local region inside the cell having a net positive charge and the outside of the cell having a net negative charge. This affects neighboring voltage-gated sodium channels, which then open, moving the depolarization along the membrane. This moving depolarization is called an action potential. Changes occur behind the action potential to restore the resting membrane potential. The voltage-gated sodium channels close and voltage-gated potassium channels open. This allows a rapid flow of potassium ions out of the cell, repolarizing the membrane so that the inside is again negative and the outside positive. This is followed by use of sodium-potassium pumps to fully restore the resting membrane potential and to reestablish proper concentrations of sodium and potassium ions inside and outside the cell.
Okay, now quickly about the other presentations. Knee pain is normally seen on the lateral aspect, as I have mentioned here, at the knee. The heel pain is generally seen on the lateral aspect of the heel. It may be felt inside the heel, behind the heel, medial side of the heel, insertion of the tendoachetes, etc., etc. Now, this is a spot which is the end of deep peroneal nerve on the roof of the sinus tarsi. Sinus tarsi is the tunnel between the talus and the calcaneus, and this is the spot. This black thing is the location of the sural nerve. This spot is between the lateral malleolus and the tendoachetes on the upper edge of the calcaneus. So this is S1, this is for L5. Now I would show when we do some injections if somebody wants to do it. What you do is for the left foot, you use your right thumb. It exactly fits in the depression here. If you ask the patient to dorsiflex the toes, there is a small prominence here which is the extensor digitorum brevis muscle. Now, important point is, why is it that L5 manifests as knee pain? Because the lateral supply of the knee is by superior, inferior and recurrent genicular nerve, which is a branch of common peroneal nerve, which is the commonest part of sciatic nerve which is affected in these affections, in these changes. So this is what was the, why is the nerve involved in tender? Effect of nucleus pulposus. This is a very important article. I would like you to read this article in detail. This is in Spine, January 2004, very, very important, extremely important article, a simple article talking about what happens. If somebody is interested, there are multiple articles on nucleus pulposus and its effect by somebody from Sweden called Olmarker, O-L-M-A-R-K-E-R, Gel Olmarker, K-Z-E-L-L Olmarker. So you can read those also. Now here I am just mentioning again, 80% have the nerve which is just tender. Why? Because it is inflamed. You inject that at the distal side, the pain goes away instantly, which we'll be talking more a little later. Mechanical compression about 15%, my sign is positive plus a straight leg raising. Now I mentioned to you about the biochemical origin of pain. That author has mentioned something important. He says that there is a universal law of pain, which is pain can only be present if there is inflammation or end result of inflammation. A simple example I'll give you. Many of you, if you're sitting with your elbows on the chair, may get ulnar tingling, etc. But you will never have pain. Why? Because there is no inflammation. If you have inflammation, it would be intensely painful. So if the person comes to you with pain, then it is your bounden duty as a clinician to detect where is this inflammation. That's in short what I'm saying, that detect where is the inflammation, how close to the dorsal root ganglion, etc. And then about 5% have compression with neurodeficit and a routine standard neurological examination is advised. The subsets of the sciatica is knee pain and heel pain, which are very important. Now, algorithm for claudication quickly, this is what we do. This is proposed by Japanese Orthopaedic Association. There are 10 questions. If 2 are yes, it is mild, up to 6 is moderate, 10 is severe. I'll just read the last one. Last one is walking nearly causes urination. I saw a patient, male aged 23, college going person. He said, sir, it is terrible. I said, what? Do you have pain? He said, no. Then I said, what is it? And he looked here, there, and he said, sir, I feel very shy. But you know, if I walk for about 10 minutes. I must go to the toilet, otherwise I wet my pants. So I said, okay, I know what it is, let's see. So then he had seen umpteen number of people and nobody was able to diagnose it. He had an intra-annular fragment at L4-5 which we removed and he became totally okay. So please remember, these things are actually happening. We ask the patient to fill up this questionnaire in his own words, in his own handwriting, etc. We do a post-word residue and then we propose what should be done. Now quickly I'll tell you, we look at this foramen. Let's say this body of L4, this is the inferior articular process of L4, body of L5, the disc between, this is the pedicle, this is the pedicle, this is the superior articular process of L5, inferior articular process of L4, this is the area which is the SAP and the ligamentum flavum, which is seen here. That star is the ligamentum flavum, which is this is the disc, this is the body, this is the inferior articular process, this is the superior articular process. Now, normally we do these cross sections like this, and then we are told that this is showing a central canal stenosis. It's not true. What we need to do is we must do imaging in this plane because the problem is posterior, problem is behind the dural sac. And this is a short, about few seconds video which I'm just showing, where I'm saying, we are on the SAP, this line tells you the angle of the gantry, then I change it and make it parallel to the disc. Now what will happen is, just watch for a few seconds and you will find what is the fraud here. Now this is in the plane of the facet where you can clearly see the ligamentum flavum goes up to the upper pedicle. Now in next few seconds you will see the traditional section like this, where you will be told that this V, see, this is what we are told, that this is ligamentum flavum hypertrophy. No. Now I'll show you some quick things. This is a publication which I have done called as coronal oblique image. Now this is available to all of you. You tell your MRI fellow to do a coronal oblique sequence, which they do for sacroiliac joint for lumbar spine. Now this is the ligamentum flavum going up below the facet joint to the upper pedicle, and it continues outside as intertransverse ligament. Okay, so this blue arrow is what is deciding thing. What is lying here towards the midline from this blue arrow is what is told to us to be the ligamentum flavum. It is not only that, but it goes up to the pedicle, and this I can show you on endoscopy, etc. Now this is just mind-boggling. This is called as a 3D fusion imaging. Okay, what do you see? This orange thing is the nerve, and you will find we are told that the ligamentum flavum is this much. It is actually here. So this horn-like thing is the one which is causative of foraminal compression of the axilla and the dorsal root ganglion. And I treat all my patients under local anesthesia through the foramen for claudication, and they become okay. I mean, we have a 5-year study which we have published, etc. So please do not believe all that nonsense which is told to us as ligamentum flavum being interlaminar. This is a cadaver specimen. Now this is important. This is a ventral dissection of the ligamentum flavum. What I mean is, you go from the front, you open the abdomen, this is a cadaver dissection, you remove the dural sac, you remove the body of the vertebra, and then you see the bed of the dural sac. This is the midline, this is the undersurface of the facet, this is what we call as the medial pedicle line, and the ligamentum flavum is about 12 millimeters outside at L5S1, and here it is a few millimeters outside that line. All these days we have been cheated by talking about something which is not there. Okay, you are told that ligamentum flavum is interlaminar. No. Now this is about that bony hypertrophy. The study is, you do a CT scan in a patient 30, 40, 50, 60, 70, and you will find the bone doesn't change. The bone remains same. Only the soft tissue which is covering this changes. So what we are saying is, this ligamentum flavum is important, but the one which causes symptoms is sitting here. This is a dorsal root ganglion coming out of the foramen, And normally we say that if you draw a line along the lower border of the body, upper body in the disc, then this SAP is supposed to be below this line. Inferior end plate line will always fall above the superior articular process. This line will always be above this. Now this is called as Cambin's triangle. He is our great grandfather of spine endoscopy. This is a triangle which is formed in the foramen between the exiting nerve with the dorsal ganglion traversing nerve and the lower end plate or the upper end plate of the lower vertebra. This yellow part is the body of upper vertebra. This blue is the disc. The dimensions of this is 12 mm vertical, 18 mm horizontal, 23 mm hypotenuse of the triangle. And this is the way the facets are, the superior and the inferior, superior facet, inferior facet. And then quickly, now this is last 1 or 2 slides. There are 7 modules which I follow in my practice. I'll just quickly tell you. The first thing is called as public awareness. Whatever you are doing, you should make the people around you aware that this is what we do. They don't know. I mean, even doctors don't know. The second is a precision diagnosis by the methodology which I told you. The third is precision treatment. Between that, we have a session of counseling. The patient is counseled in great detail about all these things. The fourth is precision treatment. Public awareness, precision diagnosis, counseling, precision treatment. Fifth is immediate post-op care. Sixth is rehab. Seventh is feedback to what we are doing. Now, important message, move away from symptoms. Move away from images to symptoms. I have not talked about MRIs as such. I have told you how you can diagnose without those MRIs, stage and localize the anatomical and physiological target. Biochemical origin of pain and universal law of pain is important. Common cytokines involved in pain I have told you. Pain mechanisms and emergence of my sign I have told you. I, by the way, published and presented this sign in Cambridge, UK in 1999. And I, same like what Prakash said, initial ridicule, people laughed at me and said, are you mad? How can this be? Are you so sure what you're talking? Whatever. Then effect of nucleus pulposus, and then effect on nerve, dorsal ganglion and sodium channels. My contribution, what I feel I have contributed is reverse analgesia. That is, you inject distally and you get relief proximally. Then dorsal ganglion is the mini brain of the functional spinal unit. So what we are doing, we are identifying the target. For that, you know the anatomy of foramen, anatomy of ligamentum flavum, physiological target. Remember, this target is sub-centimeter. So I can do my surgery through a 8 mm incision or stitchless. Use of image, X-ray, CT, MRI, extrapolating these things on the C-arm and we visualize. But there is something which is called as Microsoft HoloLens, which we are going to introduce very soon for augmented reality. And I have a distal blocker. I'll just take 2 seconds to show you. This is something which I would very soon introduce. You see something in my hand which looks like a carom striker, right? Now this has a battery inside and this can be charged by our mobile charger, and this is something similar to a TENS apparatus. This has got 2 holes on the back where we put those 2 electrodes, and this is put next to the ankle, and this is controlled by an app on my mobile. So this is a patient demand analgesia by blocking the nerves distally. I ask the patients to use an anklet with this blocker on the ankle. Patient can walk more on to whatever he likes or she likes, and whenever they have pain, immediately they start the mobile phone, they press that app. I have the app, if somebody wants to see I can show, and then you just say okay, go. It can stimulate the nerve at a very, very low voltage and the pain can immediately stop, at least for that time being. Now what has happened, because of all this which I talked, my surgery is like this. It is not open surgery or microlumbar discectomy. It is not MED or microendoscopic discectomy. It is here I cut the skin and I cut the target. And I have this which is not cut. I just dilate the muscle. And then quickly again, this is my target. In all my patients, in all my surgeries, I always land here. Okay, here in the medial pedicle line. And I call this a working rectangle, which is about 10 to 12 mm in height, about 16 to 20 mm in length. So I am operating in about 160 square millimeters, which is like the tip of my little finger. The operative area is not a football field, it's a very tiny area. So all the pathologies are within millimeters to me. Now I showed you this first picture where there was a lot of uncertainty. Here I am adding that everything you want to know is on the other side of the foramen. You have to go through the foramen to get that. I just want to show you this thing where I believe that you must always aim at excellence. You must always aim at the highest possible achievement you can do. Just don't accept some below average or just nominal, run-of-the-mill, expected quality thing. You must always produce high quality results. So I have my website if you want. This is my another website where I have my teaching lessons and taking inspiration from Prakash. Soon I would probably make my teaching website free to people. There are FAQs and answers on my website, recorded in my voice with transcription. Commonest questions asked about back pain. There are 60 questions, and all my philosophy is now transferred or transformed into Gore's system, which is marketed by Carlstrom. If some of you want to see that scope and other things, it's available there. So I stop here for my first part. I'm sorry to have exceeded my time limit, but it's like I'm involved in it.
I think it's absolutely wonderful, and it reorients us and opens our eyes towards a problem which was unknown, to at least show us a little glimpse of what is on the other side of the door.